Good afternoon, everyone. Welcome to today's webinar. I'd like to remind you that this conference is being recorded. At the moment, all participants are only in listening mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Nicholas Waters, Director of Access to Quality Mental Health Services, Mental Health Commissions of Canada. Please go ahead.
Thank you. Hello and welcome to today's webinar entitled Ghost in the Machine, Tackling Structural Stigma in Healthcare Environments. As mentioned, I'm Nicholas Waters, Director of Access to Quality Mental Health Services at the Mental Health Commission of Canada, and I'm very pleased to be your host today. I'd like to begin by acknowledging that the land which the webinar is being hosted today is the traditional unceded territory of the Algonquin Anishinaabe people. I'd like to pay respect to their elders, both past and present, and recognize the strength, resiliency, and capacity of Indigenous people in this land. Before we get started, I'd like to note that this webinar is being simultaneously interpreted. If you would like to listen to the webinar in French, please dial into the phone number on the screen. Additionally, if you are having difficulty seeing the slides, they can be expanded by clicking the 4 arrows at the top of your screen. A recording of the webinar will be posted to the Mental Health Commission of Canada's website. And if you'd like a copy of the slides, please send us an email and they will be provided. We will put an email address for my colleague, Veronique, in the chat box below. We will be discussing topics that may be triggering for some participants. We'd like to remind everyone that there are 24 hours, 7-day-a-week services that can be accessed should you need them. Contact information for Crisis Services Canada is located above the chat box, and we encourage you to use those services if you feel you need to. As I introduce our guest speakers for today, I'd ask that you please take a moment to introduce yourselves in the chat box below, as many of you have already done. Next slide, please. Joining us today, first, Dr. Heather Stewart is a full professor in the Departments of Public Health Sciences, Psychiatry, and the School of Rehabilitation Therapy at Queen's University. She also holds the Bell Canada Mental Health Anti-Stigma Research Chair at Queen's University. Dr. Stewart is also a senior consultant with the Mental Health Commission of Canada's Opening Minds Anti-Stigma Initiative and the past chair of the World Psychiatric Association's Stigma and Mental Health Scientific Section. She's a fellow of the Royal Society of Canada and a recipient of the Order of Canada. Dr. Jamie Livingston is a criminologist who studies and teaches about issues of social inclusion and social justice for people with mental health and substance use issues, with an emphasis on those who are involved within the criminal justice and legal systems. He is an associate professor in the Department of Criminology at St. Mary's University in Halifax, Nova Scotia. Next slide, please. Dr. Javid Zakira is an associate professor of psychiatry and pediatrics at the Schulich School of Medicine and Dentistry at Western University in Canada. He's also a scientist at the Center for Educational Research and Innovation at Western University. He practices pediatric chronic pain and child-adolescent mental health care programs at London Health Sciences Centre. His interdisciplinary research programs explore novel approaches to stigma reduction and bias recognition in management and health professionals. He's involved in numerous committees and councils and at the local, national, and international levels. Dr. Stephanie Nack is a senior consultant researcher with the Mental Health Commission of Canada, where she specializes in mental illness and substance use-related stigma. She has led multiple major projects for the Mental Health Commission of Canada on stigma reduction, and her research is published widely in peer-reviewed journals. Dr. Knaak holds an adjunct professorial appointments at the University of Manitoba and the University of Calgary, and she's a principal of Insight Research and Consulting. Next slide, please. Dr. Thomas Ungar, a Psychiatrist-in-Chief at St. Michael's Hospital, Unity Health Toronto, is Associate Professor, University of Toronto, with a clinical and health leadership experience as a family physician, addiction medicine provider, and psychiatrist. He is a thought leader using human-centered design to improve quality of care, addressing equity and systemic implicit bias of mental health and substance use. He's an award-winning educator, communicator, and creator of the YouTube series, Think You Can Shrink. A big welcome to all our panelists. We are very excited to have you. We are also pleased to be working with the Canadian Foundation for Healthcare Improvement, whose producers are operating behind the scenes today here in Ottawa to ensure this event goes smoothly. So welcome to everyone. As I mentioned earlier, we are pleased to provide simultaneously interpreted dialogue for today's webinar. This may result in a few quick pauses in conversation today, but we invite you to participate in our chat box today in either official language. Next slide, please. To review our agenda, we'll be covering the Mental Health Commission of Canada and our work in stigma. We'll quickly talk about what is structural stigma, and then go on to our panel presentations, followed by, most importantly, a dialogue with all of you. If you do have questions, please type them into the chat box. And if you have a question for a particular panelist, if you could please mention that in your chat. If it's open for everyone, we will do our best to have each panelist or a panelist that makes the most sense to answer that particular question. Next slide, please. For anyone who is not familiar with the Mental Health Commission of Canada, we are a not-for-profit organization created by the Government of Canada in 2007 on the recommendation of the Senate and Social Affairs Committee stemming from the report Out of Shadows at Last. Our initial mandate included At Home Chez Soi, the largest research demonstration project on housing first in the world, the development of a world-class knowledge exchange center, the creation of the country's first mental health strategy, and our Opening Minds Anti-Stigma initiative, which I'll speak to in a bit. In recent years, we've focused on many other initiatives, including suicide prevention, e-mental health, workplace mental health, substance use and mental health awareness and stigma reduction training, to name a few. Our new strategic plan will be found on our website soon. Next slide. Next slide, please. Our Opening Minds initiative, which I mentioned earlier, started in 2009. The initiative worked to identify existing anti-stigma programs, assess their effectiveness through scientific evaluation, then promoted the successful programs throughout Canada. Next slide. Through this work, there were 4 targeted identified groups: healthcare providers, youth, the news media, and the workplace. The Mental Health Commission of Canada subsequently identified, evaluated, tailored, and developed a number of programs targeted at these groups, including the Working Mind First Responder, Understanding Stigma, the Inquiring Mind, the Mindset Guidelines, Headstrong, and many others. Next slide. Stigma is manifested in many different ways, including through labels and language, stereotypes, discrimination, unjust policies, laws, institutional practices, and many more. Next slide. What is really important is that stigma is a social process and needs power to exist. Next slide. Stigma operates at 4 different levels. The individual level, which includes shame, fear of seeking help, and feeling less worthy. Interpersonal stigma, endorsing negative stereotypes or prejudicial ideas and speaking or acting in a discriminating way. Structural piece, which is located in formal and informal rules, policies, procedures, and laws and cultural norms. And intersectional, the many ways stigma related to mental illness and substance use intersects with other forms of oppression, for example, racism, transphobia, and colonization. At this time, I would like to pass it over to Dr. Heather Stewart, who will get us started with our panel presentations today. Over to you, Dr. Stewart.
Thank you very much, Nicholas, and welcome everybody. It's nice to see people from all over the country in the hot areas and the really cold areas today. What I wanted to share with you today was a little bit about what we learned when we spoke to people who had firsthand experience with structural stigma. That was really an important starting point for us. So we conducted a qualitative study as part of this larger project, and what we wanted to learn was about the range of structural stigma experiences that these folks had. We talked to 20 different people who formed a broad cross-section of Canadians, all of whom had some experience with a mental and or substance use disorder. And these included youth, Indigenous peoples, mental health advocates, clinical care workers, and peer support workers. And sometimes people wore more than one hat. What we learned very quickly was that the participants didn't have any difficulty identifying experiences of structural stigma in healthcare settings. Indeed, they painted quite a grim picture of the nature and effects of structural stigma in healthcare settings, and identified outcomes that range from disempowerment, disenfranchisement, dehumanization, treatment avoidance, disability, and even premature death. So that we learned a number of things from this project. There were significant problems with the culture of care in many settings, where staff interactions and even the processes of care were experienced as demeaning, dehumanizing, robotic, and traumatic for many people. The staff didn't seem to be able to relate to their patients as people and often showed little awareness of recovery principles. They emphasized medication and symptom remission to the exclusion of more recovery principles that would help people develop new roles and relationships and progress through a meaningful life. People with substance use disorders recounted some of the most difficult experiences, including barriers to care, fragmentation of care, and premature mortality. Next slide, please. So we learned a number of things also about potential solutions. And there was no shortage of these either. These included making changes to exclusionary healthcare policies, looking at policies with a structural stigma lens, improving curricula for emerging professionals, so the nurses, the doctors, people who are coming through schools, improving continual professional education for those that are already in the system, and providing training and support for healthcare providers. The participants considered that the processes and pathways of care needed to be more culturally sensitive, and by and large that meant person-centered, more caring, and definitely more recovery-oriented. Peer support workers were identified as essential, especially in terms of helping people go through the recovery process, but it was recognized that these were not readily available within many mental health or substance use services. Participants also agreed that the culture of care should be monitored and assessed using standardized metrics. If we can monitor and measure what's going on, then we have the possibility of identifying areas where we can make significant change. However, they also stressed the importance of including people with lived experience in all aspects of this type of reform, and they especially wanted input into the outcomes and processes of care that would be monitored through a measurement process. They wanted to make sure that the outcomes that were being measured were important to them, not just important to the healthcare system. And finally, they recognized that most of the quality of care skills that were out there were developed by researchers for researchers, and they wanted to have meaningful input into their further development, testing, and applications. And I'm happy to answer questions about detailed experiences that folks had in the question and answer period, but for now I think I'll turn it back to Nicholas and just apologize for not being visually present. I think I'm the ghost in the machine today, so there you go. Thanks, Nicholas.
Thank you very much, Heather. Moving on to our next panelist, I would like to turn over the virtual floor to Dr. Jamie Livingston.
Thanks, Nicholas. Good morning and good afternoon from Mi'kmaq, the unceded territory of the Mi'kmaq people. So when I acknowledge the land of the Mi'kmaq people, it's also important to draw attention to the fact that the effects of the injustices and inequities we're talking about today are particularly potent for Indigenous people and other oppressed communities whose health has been severely compromised by colonialism, by anti-systemic racism and structural stigma. Well, we know that people experience structural stigma across numerous social contexts and domains that are depicted on the left side of the slide. And over the past 2 years, I've worked alongside these panelists to examine how structural stigma manifests in healthcare contexts, specifically in relation to inequitable access and poor quality of healthcare. And today, in the brief time that I have, I'd like to touch on how structural stigma is expressed when coercion is woven into our healthcare institutions, such that it becomes the norm by which our institutions operate. And because of this, people with mental health and substance use issues expect to be treated in a coercive, paternalistic, and punitive manner when they engage with healthcare providers and with our healthcare services, which ultimately discourages people from engaging with the healthcare system. When I talk about coercion, it simply means pressuring someone into doing something. like a healthcare provider compelling a person to make a particular healthcare decision. And coercion exists on a continuum from gentle pressure all the way through to compulsory interventions that impinge on people's liberty rights. And it includes limiting people's choices by not providing them with treatment options. Now, coercion is embedded within healthcare policies and in practices in a range of ways that contribute to structural stigma by arbitrarily restricting the rights of people with mental health and substance use issues. We see policies that promote the overdependence of compulsory forms of care, including involuntary hospitalization, forced medication and treatment, restraint and seclusion, and compulsory community programs that infringe on people's rights more often than they should and for longer than they should. We also see the increasing entanglement of criminal justice processes and security technologies and personnel into the mental health and substance use systems, such as the routine involvement of police and security personnel in responding to people who are in distress. We also see people being threatened with punitive sanctions, such as being rejected or ejected from healthcare services for issues that are directly related to their substance use or mental health issues. The risk of these punitive sanctions is particularly true for people who are using criminalized substances. And we also see that people have inadequate access to rights-based information and poor access to legal and advocacy services to challenge arbitrary restrictions that they face and to challenge the unfair exercise of coercive practices within the healthcare system and by healthcare providers. So it's clear that coercion is baked into the laws, policies, and practices of our healthcare systems in ways that detrimentally impact the quality of services and are viewed by people with lived experiences as institutionalized forms of stigma. But it's also clear that there's a range of approaches for addressing structural stigma in healthcare, including eliminating and reducing coercive policies and practices. And I'm sure we'll get to this more during our discussion, but I'd like to highlight one critical approach that is threaded throughout the literature on structural stigma, which is involve and support people with lived experience in identifying healthcare policies that either promote or fail to prevent coercion, paternalism, and punitive practices in healthcare settings. So as Heather mentioned, view people with lived experiences who are facing structural stigma as agents for change in the healthcare system, and then meaningfully involve them and empower them in developing and implementing solutions to reduce structural stigma. So that's all the time that I have. I want to thank you for taking the time today to learn more about structural stigma, and I look forward to the discussion.
Thank you very much, Jamie. Our next panelist, I would like to hand the virtual floor over to Dr. Stephanie Nack. Stephanie, you are muted.
Sorry, can everybody hear me now? Thanks, Nicholas, for that. Hello, everybody. So what I'm going to talk about today, very briefly, is the slide that you see in front of you. And this slide really provides a very high-level summary of what came out of our first year of research in terms of identifying what are the key priorities for addressing structural stigma in healthcare environments. And that first year of research was the qualitative project that Dr. Stuart spoke about, a literature review that Dr. Livingston undertook, and a study on measures that Dr. Ungar undertook. So hopefully you can see the screen today. There were 7 priorities that were identified, and instead of going into each of these priorities in great detail, I thought what I would do is offer a bit of contextualization instead, because I think they're actually fairly straightforward and intuitive what these priorities are. So one of the things I really want to stress about these 7 priority areas is really that they should not be thought of as independent or mutually exclusive categories. Rather, they should be thought of as highly intersecting and overlapping and positively reinforcing categories. So in fact, the more categories that are represented when you are implementing a change or an intervention or a strategy or an initiative, the better, and the more likely that you are going to be successful in making a truly lasting, meaningful, and true change in the particular area or the structure that you are actually trying to address. So maybe I'll just illustrate with an example. So if we look at the first priority area of improving attitudes and practices of staff, which might involve the implementation of some education or training initiatives, or could be done through modeling or mentoring, or some other approach. But let's say an organization is wanting to address this priority by focusing on education and training, combined with ongoing modeling and mentoring and reinforcement activities. What this model of priorities tells us is that when you're thinking about delivering education and training to reduce structural stigma, we need to also be thinking about ongoing monitoring and measurement, which is the second priority category that you see, because of course what gets measured is what gets addressed. And we need to make sure that we are tracking changes and outcomes, not just at the level of individuals and individual change, but at that higher level of organizational culture and that broader culture of caring that Dr. Stewart talked about, which is what gets you to the structural. So including, for example, ratings of client satisfaction over time, as well as measures, say, of provider attitudes or orientations to caring over time. And again, measured not just at the level of individual, not just measured in the short term, but actually embedded and measured over the longer term. So you get a sense of what's happening at that entire organizational level or unit level or department level. So in addition to measuring and monitoring, we also need to be thinking about how we're meaningfully involving or taking the lead from people with lived experience of mental illness or substance use problems in the design and delivery of any kind of training we're undertaking, as well as in the ongoing monitoring and evaluation of the training and its impacts. Also, we need to be ensuring equitable resource allocation to the design and implementation of the training so that it is in fact sustainable, that it's embedded, so that staff can be incentivized to attend if necessary, and so that it can be offered on an ongoing, reoccurring basis as opposed to just a one-off kind of let's check the box training, which is often, unfortunately, the case that we see with training of this kind. Because again, that's actually how you get to changing structures. By committing, and even just committing to equitable resource allocation for this kind of education and training is in fact, would be an example of structural change already. We've also learned from our research that education and training, even when it's done really well, is still only one piece of the puzzle when it comes to improving attitudes and practices. As Dr. Livingston and Dr. Stewart have already talked about, we know that we need to be taking a closer look at our models of care and moving towards really adopting models of care and care practices that are truly recovery-oriented, that are trauma-informed, that are patient-centered, and that are coordinated. And this also means then committing to look at our established policies and practices, both informal and formal, as well as our legislation, to ensure that the principles we're wanting to promote through education and training is actually reflected in the policies and practices that ultimately guide our behaviors and our approaches to care. The last priority that you see on the slide in front of you across the bottom of the figure is really a foundational piece. I think that speaks to the culture of healthcare as a workplace and the need to be building a workplace environment where the people who work in healthcare feel supported in addressing their own mental health needs, where psychological safety is a priority, and where they feel supported in their careers and in their workplaces. And in the context of the education and training example to improve attitudes and practices of staff, one thing we are learning in our research is that shared humanity models can work particularly well in this regard. So this means that the training is not just outwardly focused, say on improving client care and improving attitudes, but it's also inwardly focused to address the needs and the vulnerabilities and the stresses and the experiences and the implicit biases of healthcare providers as well. So I think I'm going to leave it there for now, but before I hand the mic back to Nicholas, I'll just perhaps end on one note, that even though these 7 priorities are definitely intersecting and overlapping, I really want to stress the importance and value of ensuring meaningful participation of people with lived experience with mental illnesses and substance use problems throughout all aspects of decision-making, care delivery, training, and research. So if there's one takeaway, or if you're looking for a simple, like, where do I start in all of this with respect to this model, I would say start there. Because if you truly commit to just this one priority to start, it will naturally intersect with and lead to all of the other priorities. I'll stop there. Thank you very much.
Thank you very much, Dr. Nack. Our next panelist is Dr. Javid Zakira. Over to you.
Thank you so much, everyone, and thank you for the opportunity. Can I just get a nod if you can hear me okay? Great. So my work started with the lived experience of being someone in practice and witnessing discrimination. I watched as my patients and people who I worked with experienced consistent blame and shame from the healthcare system. I watched when a young person might build up the courage to finally ask for help and then encounter a health system that didn't respond in the ways that it should. And I watched as these experiences built up over time and had strong implications for this person's future. We know that the system is not built with the needs of those individuals struggling with mental illness and substance use problems in mind. Yet at the same time, I also felt like existing approaches to stigma reduction seemed to be flawed. We know that providing basic education programs or lessons for people about the negative impact of stigma simply is not enough to change people's behavior or attitudes. We also know that shaming people who might demonstrate negative beliefs or behaviors towards mental illness can actually make stigma worse by triggering a defensive and potentially counterproductive reaction. Many stigma reduction programs start with this kind of assumption that there might be bad people who stigmatize and good people who don't. And training often makes participants feel judged for stigmatizing others, especially when they don't mean to stereotype. We know from science that we can all be guilty of perpetuating stigma. That is that despite our best intentions, we're all a product of our upbringing and susceptible to the messages around us. If we start stigma education with a default assumption that we all hold certain types of stigma and that we are all going to be working towards eradicating it, we can start to have a different kind of conversation. So our initial work took a different approach. We co-designed and developed the first of its kind implicit bias training program, really focused at implicit stigma recognition and management with health professionals. We researched our training, we conducted in different contexts, and we had lots of lessons from this longitudinal evaluation. It became clear very quickly that changing minds is not enough. Structural forms of stigma are baked into the system. They're baked into the fabric of our society and organizations at large. Any educational interventions that are directed towards individuals without an appreciation for the ubiquitous nature of structural stigma will ultimately fail. Placing the onus on individuals to address widespread organizational inequities can also contribute to a sense of futility and helplessness. So in the longitudinal evaluation of our work, participants initially shared that they were inspired to change, that they wanted to be better, but they felt like they were swimming against the current. They described how structural stigma embedded in their organizations in areas like triage, prejudicial underfunding for mental health services, or various models of care would actually contribute to inequity despite their efforts as individuals. Yet as we followed them over time, they recognized that by being more critically aware of how they played a role in perpetuating and could correct stigma, that they began reflecting on things that are structural that need to change. I remember one of our participants describing how they had the realization after the training that there was a policy, a violence prevention policy, and a tool that they felt was inherently stigmatizing. Rather than just throw up their hands and accept this, they actually worked with their team to co-design structural change. And these findings highlighted for us that training complements structural change, but only if the right conditions are met. Training designed within a transformative learning paradigm may hold tremendous promise for actually helping us to dismantle structural stigma. Now from these findings, it created momentum for us to continue our work to observe and understand structural stigma as it's enacted in practice. And for example, we've recently concluded a study where we looked at implicit, explicit, and structural forms of stigma in hospital units towards people who inject drugs. Now while the work is ongoing, we've learned a great deal, and there are a few key lessons that align with some of the lessons that we've learned from other speakers today. Number one, as you'll see on the side, we can break the cycle. What we do in the moment matters. Stigma is all around us, and we can easily fall into its traps. Rather than fall into coercive power struggles, when we encounter emotionally charged moments where we might be part of perpetuating stigma, we have to learn to literally and figuratively pause as we critically reflect and reframe what we're seeing at the tip of the iceberg or happening within a context that might be quote-unquote clinical, and reframe it into structural terms. What's really happening in this moment? What can we do to reframe and respond in a way that breaks the cycle? Just one small moment of connection and reflection has that power. Number two, as noted by other speakers, stigma is intersectional. Terms like structural stigma and implicit stigma, they're redundant. Stigma itself is implicit, explicit, and structural, and addressing any form of stigma requires addressing all forms. That's why changing minds is not enough, and dismantling structural stigma requires power and policy change. Number three, the role of self-compassion and self-forgiveness. Many of us who seek to fight stigma can often be extremely hard on ourselves. If we want to be part of change, we must recognize and embrace that we're inherently imperfect. Our research would suggest that stigma reduction must be framed in a manner that teaches us we can strive to be better, but we have to embrace and accept our vulnerabilities. We also need organizations who have our back, who walk the walk, and stray away from performative stigma reduction. And last, shifting from blame to accountability. Our power is often invisible to us. We often point the finger at others to act, yet we forget that we are part of the system. We can start the process ourselves. For those of us who work in the system, this actually means we need to create space for those who experience stigma to lead the way as we co-design structural solutions together. Thank you.
Thank you very much, Dr. Sukhera. And last panelist, but certainly not least, I will turn the floor over to Dr. Thomas Ungar.
Thank you, Nicholas, and hello, everybody. And it's so great to see everybody from all across Canada. This work is some of the most meaningful of my career, and the structural stigma research team and the work of the commission is really inspiring. So it's a wonderful opportunity. I am a healthcare provider. I spend half my time seeing clients, and I have the privilege of leadership positions in a couple of different hospitals. So I'm in the belly of the beast of both working within as well as helping to oversee and organize some of the healthcare system. Having worked a bit as both educating other health providers, what's become very apparent is it's not just a knowledge barrier, it's an attitudinal barrier that's often the challenge for them. And structural stigma, beyond the individual interpersonal, has very interestingly been something that is not only an intentional, but often an unintentional thing. It's hard to see, it's hard to understand. And I know, having worked with healthcare providers and having had them care for my children or myself, they are well-meaning people. They do not want to be doing this for the most part. But it is not something that all healthcare leaders are aware of. It's a little bit of a hard concept to wrap our heads around. And it is exceedingly important to the mandate of improving quality care and delivering great quality care in Canada and everywhere, really. So structural stigma is a very unusual thing. People understand the concept, but what our work has done is, even though people may kind of think they know what it is, it's not until we did an external scan to see, is anybody measuring it? Is there actually a measure or tool to measure structural stigma? And what was interesting is the concept is one thing, but how it actually manifests and implemented and how those actions occur in a particular context are unique little stories or examples, in some cases indignities or inequities and injustice. And that's what really resonated. So part of our work in our external scan was to contact agencies to see, is there a tool you know of? And really nobody identified this. And started to float prototype ideas of little examples of how it manifests in your context. And that really kind of flipped the switch for people to see, oh, I thought I really got what structural stigma was. But until you showed me a policy that the cleaning services in the mental health area of the hospital are not the same as the cleaning services in the surgical part of the hospital, oh, that's what you're talking about. And we've collected and listed a variety of these examples in some of the publications on the Mental Health Commission website of structural stigma. So this concept of structural stigma, particularly of mental health, mental illness and substance use disorders, is right in the wheelhouse of and the mandate of healthcare leaders and decision makers. And that's why we're really targeting some of the work to those people, because that's where that awareness and those decisions are of such importance, because really they're kind of hidden. And the receiver of services may not realize until you get into the belly of the beast to see where those policies and structural barriers are, or maybe you experience parts of them, and that's what we're really trying to get into. I sit at the table, as do some of you, looking at a quality dashboard, a performance dashboard, a metric to see how the healthcare service, your organization, your region, your hospital is performing. And in some cases, a green light shows up where you're doing well, a yellow light where it's not great, or a red light flashes. And in some cases, those red lights are even tied to funding transfers and the amount of money an organization gets for that performance. Do you meet your wait time targets? Do people have access to services? So seeing that this framework of quality of care is being used inherently throughout healthcare, we thought, wouldn't it be a unique, easy way to leverage that system and hack the healthcare system to try to build in measures or capture things in the method that's already capturing quality of care, and see if we could use that to surface and make explicit some of the structural inequities and barriers. And quality of care is measured under 6 pillars: safe, effective, patient-centered, timely, efficient, and equitable. And under each of these pillars of quality, we have dashboards, but there's pretty much nothing that speaks directly to structural inequities or structural stigma related to mental illness and substance use disorders. So we are working on identifying some of this. For safety, things like, do persons admitted to hospital get a physical exam for all conditions equitably? They may not. For other things in equity, it may be cleaning services. It may be the condition of the physical space. It may be the wait time once you are on a list for services. We do measure that for orthopedic procedures, cataract surgeries, cancer care. Can we also measure access and wait times to quality mental health services? This is the way we're trying to get the structural stigma concept into actual operational issues that resonate, that we can actually take action on immediately, even if the people aren't aware of why they're taking that action. And I do think most of them want to take it for the right reasons. And in doing this, what we've realized is, particularly under the equity pillar, many of these inequities may sit very nicely there. And even though we've been doing this work for quite a few years and the groups come together, of course what happened in society with the equity, diversity, and inclusion issue has become huge. And many organizations are actually trying to address implicit bias in a variety of things, ethno-racial, gender, and other issues. And really mental illness and substance use disorder care within the healthcare context is its own implicit bias, is its own equity issue, one that may not be recognized or thought of because it's so normative, people don't even see it. It's really quite remarkable. And in doing this, we're starting to talk about structural stigma being operationalized, these behaviors, as its own implicit cognitive bias. And cognitive bias is a well-recognized quality error that leads to mistakes, leads to bad outcomes and incidents in healthcare that emergency physicians, all healthcare providers know about and are trying to capture. And the interesting thing about cognitive errors and biases is they're not intentional. It's not the individual who's bad or not doing it right. It's how do we structure a system that captures these human factor realities, because people aren't perfect, and kind of protects us for them so that the safer, more equitable, more correct quality of care is delivered despite ourselves. While in the background, the work of understanding that bias and trying to change your attitude comes along. So really, leaders and healthcare systems are starting to really recognize cognitive bias and implicit bias. And I think the same quality measurement method and trying to figure out those operational realities downstream of how they actually manifest, which are a surprise to people. They're a bit disorienting and upsetting to hear about by kind people who want to deliver good care. Nevertheless, they're operationalized as marked inequities. It could be funding inequities, wait time inequities, access to service, differing life expectancy outcomes that are shocking, that aren't really being captured currently. So that's what we're trying to make explicit. The idea being if we can measure them, monitor them, declare them, they'll result in behavior changes for the improvement of health for all. Thank you very much. I think I'll stop there.
Thank you, Dr. Ungar. This is the point in the webinar where we will do some question and answer with our panelists. When you registered for today's event, you would have had the opportunity to submit some questions in advance. So I'm going to toggle between questions that we received when you registered and do my best to answer or to triage the questions that are in the chat. Just for everyone's knowledge, after the webinar, we will do our best to answer as many of the unanswered questions as we can, and we'll post that alongside with the recording of our webinar. The first question, and again, if you do have questions for a particular presenter, if you could put their name in front of the question, that would help me ensure that I'm asking the right panelist. But I'm going to start by asking Dr. Stewart, how is structural stigma experienced, and how does it impact frontline workers and patients? Over to you, Heather.
Thanks so much for that question. The interesting thing about organizational structures is they can create processes and pathways that govern the way people within the organization behave. So healthcare workers can be very much involved in stigmatizing processes, even if they don't want to be, just because of the way the organization works. And so this is where the big example that comes into my head is when I've gone to psychiatric facilities and community care centers, the first thing I notice is all this plexiglass everywhere. And it just gives me such a horrible feeling that everybody is so afraid that they're in their own bubbles. And one of the experiences we heard from the folks in our focus groups was that they could tell which nurses were more recovery-oriented because they would come out of the fishbowl. The other ones stayed in the fishbowl for the most part and didn't want to interact. And so, you know, the way in which the organizations even organize the space can have a huge impact on the people on the receiving end of the stigma. And it doesn't make them feel very good to be treated in this way. I mean, it's disempowering to, you know, everywhere look around and feel that you're somehow a public risk or you're dangerous, just simply because you have an illness. And so, you know, I think we have to think about how organizational processes of care and even the architecture of madness, if you want to think about it in those terms, can really you know, impinge on people's self-esteem, their self-worth, the recovery process that they're following through. And so I don't know if that entirely answers the question, but it does give some examples of how this kind of plays out in a very covert, sometimes unintentional way.
Thank you very much. I'm going to pass it next to Dr. Sukhera. Do you have anything to add to Heather's response?
No, I think it was good. Thanks. Okay.
Thank you very much. The next question that came in during the registration, have the incidences of structural stigma in healthcare environments increased amidst COVID-19? And I will first pass it to Dr. Nack.
Thanks, Nicholas. Great question. And unfortunately, you know, not being a clinician and this not being my primary area of research, I don't have the answer to that in that context. But I do have a story in the context of another project that I'm involved with that potentially speaks to a good news story in relation to structural changes in response to COVID. And this is the implementation of virtual OAT that was developed as a response to COVID. And in this particular project and with this partner that we're working with, the early evidence is coming back that that by being able to offer OAT virtually, they are finding that they are attracting a wider client group where people are showing up and coming into care that haven't previously come into care, and that they're also seeing higher retention rates. And the thinking is because the virtual environment is perhaps less stigmatizing, that they feel a little bit safer coming into care, and that it's also more convenient. So there's some of the access barriers that have been reduced. So that's just one comment I have as a suggestion.
Thank you much, Dr. Nack. I'll turn it back to see if Dr. Zakira, do you have anything to add to Stephanie's response?
I do. So I think that there's lots of lessons for what's happening with the pandemic, and structural stigma, I think, has emerged in many cases where mental health really hasn't been in the table as part of rapid crisis-based pandemic policy development. So, for example, we can see that reflected in redeployment decisions in the early days of the pandemic. If mental health staff in an organization are redeployed what's left for the people who might be in mental health crises in terms of meeting their needs. We can also see it in terms of the ways in which congregate settings are viewed. We know that the pandemic has had a disproportionate impact on those who live in congregate settings. However, many people with severe and complex mental illness that live in such settings aren't always on the radar of policymakers when it comes to equity, access to personal protective equipment, as well as now a vaccine distribution. Ultimately, I think the key is having people at the table and making sure that in the crisis situations that we might find ourselves in, that there are still people who understand and appreciate mental health and substance use problems, because if we design a system without those people at the table, the system's not going to meet the needs of people who might be struggling.
Thank you very much. The next question that came in the chat. So across the country, there's a renewed focus on reducing police response to crisis and diverting people to healthcare. Given structural stigma in healthcare settings, where should the focus on services be? I'm going to turn over to Dr. Livingston.
Thanks for the question. So, the criminalization of people with mental health and substance use issues is a form of structural stigma, and that often the criminalization is linked to the inadequate resourcing of the mental health and substance use service system itself. And this ties to my presentation on the introduction of coercion and the overuse of coercion as a way of delivering mental health and substance use services. So of course, especially following the Black Lives Matter action with last year, but even preceding that, there's a lot of questions that have been raised about how we're increasingly relying on criminal justice system as a way to deliver mental health and substance use services, and a lot of critical questions being asked of the role specifically around with the police in responding to crises and responding to overdose calls, and how that has a negative effect on many people, but especially within communities who've had really histories of poor treatment with the police, making them reluctant to access mental health and substance use services. So I think part of destigmatizing and addressing structural stigma means this sort of transformative change that involves doing things intentionally to remove the criminal justice system and criminal justice agents from the delivery of mental health services with the goal of reducing coercion and paternalistic practices.
Thank you very much, Dr. Livingston. Lots of great questions coming in the chat, and that came in with registration. As I said, we won't be able to answer all of them here today, but we will do our best to follow up with all of the questions to provide responses. So the next question that came in is, what type of educational interventions are available to address structural stigma? And for that, I'm going to pass it over to Dr. Ungar to expand on some of the work that he has been undertaking with the team.
Yeah, thanks, Nicholas. So it started to become mandatory if you sit on a selection committee in an organization that you have to do some mandatory implicit bias training modules. That's kind of occurred over the last 2-3 years, really picked up now. My organization has now got some EDI, equity, diversity, inclusion training, and that's relatively new, a lot of transformative learning and reflective kind of exercises, which is terrific. But in our external scan, we've not identified anyone who's yet doing specifically to mental illness and substance use disorders that we're aware of, or it's in very early days. Our group is actually, as a precursor to the other interventions to help people understand it, developing an implicit bias training module with the help of instructional delivery designers from CAMH that we're working on actively. We have a committee with persons with lived experience, of course, an educational committee, and we're working on that. The reason for it is that it's really hard to implement some of the solutions by leaders and agents of change if they don't even think it exists. So it's almost like an early stage pre-contemplative, contemplative transformation. Someone has to kind of get woke to the concept, oh my gosh, I thought we were so equitable. I didn't even notice that the fact that we segregate mental health and substance use in a different building or a different part of the hospital or in a different agency or in a different data capture system that we do, that I didn't even really think of it that way. So we have to kind of go through that kind of education and awareness conceptual reframing, paradigm shifting first, because that really then helps people get on board with what they need to do, because I don't think they want to be doing this. So our module is really the first one we're aware of, and that should hopefully be ready in April or May to be launched if all goes well.
Thank you very much, Dr. Ungar. This question is directed to all panelists, and so I will look for a hand being raised and give the opportunity for Dr. Stewart, who's on the line, to respond first if she wishes. The question is, does it make sense to link anti-racism, discrimination, bias, and stigma efforts together as part of an evolving framework that supports various vulnerable populations and groups? And if so, what are the speaker's thoughts for how to successfully go about doing this? And
thanks. I will go first if you don't mind, if you can hear me. Yeah.
We can.
It makes a lot of sense to link some of these experiences together because there's so many similarities. And one of the things that we haven't had in the mental health community is a strong voice. Many times healthcare providers or family members or other people speak on behalf of those who have experienced a mental illness or experienced discrimination. And so it makes a lot of sense to do that. But at the same time, any time that the mental health community has tag teamed with anyone else, they always end up at the bottom of the heap somehow. And there's really a lack of understanding of some of the political and historical challenges that people with mental illness have faced over the years. Not to just take anything away from the other groups. They've had their own challenges. But I think sometimes that gets lost. And so I think there's definitely room for putting our heads together as a larger advocacy community and thinking about how can we collaborate to get things done. But I also think we have to make sure that our needs in the mental health and substance use systems are also being met. And those might not always line up perfectly, so we just have to be thoughtful and careful as we go forward and make partnerships and allies when it seems reasonable to do so.
Thank you, Dr. Stewart. Any of the other panelists like to respond or add on? Dr. Sukhera?
Thanks. So I would completely agree that all forms of inequity are linked and intersectional. One of the ways in which we've approached this with our initial work is by really emphasizing the concept of shared humanity or common humanity that was raised by several speakers. Everyone has a lived experience, and everyone, by virtue of our humanity, knows what it's like to feel vulnerable. So approaches that seek to tap into that experience can actually help catalyze a different way of approaching and understanding inequity. The challenge, though, is that many existing paradigms for equity education can fall into traps that can be blaming, shaming, and finger pointing. So the idea behind some of our work is that before you point the finger, we have to look in the mirror at ourselves and at the systems in which we work. What it also points to is that those of us who haven't experienced certain forms of inequity shouldn't be taking up the space, which is our instinct to do so, right? That we're the good people, we're not part of the problem. The truth is we're all part of the problem, and that can be scary, but we're also all part of the solution, and that can be hopeful. What it requires, though, is for those of us who work in the system and those of us who have structural power to create space and build those solutions alongside others. And in other forms of inequity, it's to create space for people who might have lived experience, whether they might be racialized, etc.
Thank you very much. Would any of the other panelists have a response? Seeing no hands, I will move on to the next question. So how can healthcare organizations combat structural stigma, and what are some quick and inexpensive ways that organizations consider, particular smaller ones who may not have significant budgets? Any of our panelists like to
I can start
respond?
on that. I mean, pretty much every healthcare organization has to answer to somebody for oversight of the quality of the care they deliver, usually to the province or whoever healthcare is delivered by. So I think looking at what those accountabilities are, whether it's a policy, a measure, a metric, an accreditation item through Accreditation Canada, your CHI metrics, your reportable things, usually there may be nothing in there. So if we could even build 1, 2, or 3 accountabilities into there, and that's part of our strategy with the regulators who are looking at performance measurement and audits and to ensure the equitable quality of care. If you can't identify anything, you can pilot one yourselves. You can look at the list that we're developing, you can see what's coming, and see if you have anything specific to structural stigma of mental health. And it's figuring out what might be a manifestation of that in your healthcare delivery organization, in the work you do that speaks to that. Maybe the memento of injustice that bothers you, and can you do something? For me, it might be that the paint in the mental health area is not the same quality of being kept fresh as the paint on the walls in other parts of the hospital. And you actually build one of these silly things in, and you try to track and report and measure that. Therefore, it doesn't require individuals to think of it. It just becomes part of the routine, mandatory, systemic monitoring system, and the system hacks behavior to hopefully have quality improvement occur.
Thank you very much, Dr. Ungar. With only a few minutes left, I will just ask a couple additional questions to our panelists. This question is for Dr. Livingston. How does structural stigma and trauma-informed practice relate and interact with each other?
Well, often when you hear about the experiences of people who face structural stigma within the healthcare context, they often speak about the traumatizing effects of the interactions, of healthcare interactions, that clearly we're not following a trauma-informed approach. And so, restraining someone or putting them in seclusion is obviously very traumatizing for people. Looks like I've lost my camera, but I'll keep speaking anyways. So I think one of the ways, of course, to reduce structural stigma is, of course, building upon a foundation in which healthcare systems don't continue to traumatize and re-traumatize people through their engagement in healthcare systems. So I think that's an important question, to think about the linkage between historical traumas when we're thinking about, practices that oppress Indigenous people and things like that, and their historical linkage to healthcare institutions, but also ongoing traumas and the way in which healthcare professionals are trained in ways that can diminish the trauma that people who receive services experience when they interact with the healthcare system.
Thank you very much, Dr. Livingston. Any follow-up from our panelists or Heather on the line?
No, but I do want to point out one area where I think we need to do a lot of work, and I think it's circumscribed enough that we could make some change there. But people who end up in emergency rooms really have very little good to say about them. They're put in a box, the security sits at the door, people are, asking them over and over and over again for their details on what happened. There's no sense of person-centered care in many emergency rooms in the country, and I think that we could think about how could we provide better, more caring, more supportive emergency rooms and the emergency experience for people who have mental health or substance use problems and their family members, and that would include making sure that folks get appropriate medical clearance in case they have physical problems that aren't noticeable or aren't being addressed, and how their consent is obtained, how things are explained to them, the transparency with which the processes are delivered. And I think that most everybody I've ever talked to who's been in an emergency room for a mental health crisis has been traumatized by it. So I think if we wanted to put our collective heads together, that would be one area where I think we could make some important differences.
Thank you very much, Dr. Stewart. And in the excitement of all the questions coming in, I read my clock wrong. We still have a fair bit of time, so apologies for that, so we can get to many of your other questions. This question I'm going to start with Dr. Nack. How might lessons learned from healthcare contexts be transferred to multidisciplinary contexts or community-based organizations? What are the core competencies to drive change at the organizational and structural levels around stigma?
Thanks, Nicholas. Great question. So I might pull a bit from a current project we're working on, which we're calling our Champions and Changemakers project. And this is a project, essentially a case study, project where we're highlighting and learning from real-life examples of different organizational initiatives that are making changes within the system and trying to address structural stigma. And there are definitely a number of kind of high-level themes that have come up over and over again. And so I would say one of them is having that strong leadership support. So having the champions in the system and the support from leadership and the drive from leadership. Another one is a commitment to collaboration. And we heard through these case studies that you don't necessarily have to be an expert in engagement and client service engagement, but you do have to have good collaboration and teamwork skills, and you have to be committed to that collaborative process in terms of involving people with lived experience. So that might mean, however you're involving that participation, whether it's a shared governance model, whether it's shared committees, whether it's co-design, and you have to just be willing to sit in the uncomfortable space and have uncomfortable conversations and difficult conversations, because they will come up, and you are going to have to problem solve. So it's just having the skill to basically all be on the same page and agree to work together. I would say another important thing that came up is the importance of formalizing processes. So when you are wanting to implement a change, we heard the story that John Smith has this great idea and is moving forward with this wonderful initiative or program or change or whatever, and all these wonderful things are happening, but then John Smith moves to another department or retires or something happens. And if those processes and those changes haven't been formalized or embedded somehow, then the risk is that it falls apart. So there's, I think, a few transferable themes that can be applied in all kinds of different contexts.
Thank you very much, Dr. Nack. Would any of the other panelists or Heather on the line like to add anything? Hearing none, I will move on to the next question. The next question for all panelists. I'm curious to hear the panelists' thoughts on family and peer support and the value that families' voice may add to combating structural stigma. Families try hard to support their loved ones and are often seen as part of the problem, which is also stigmatizing. I will open that up to any of the panelists who would like to start as a response, and then to others after that. Dr. Sukhera?
Yeah, so I think we have to be very candid here that it's not possible unless we are guided by and led by voices of individuals who experience the system and their caregivers. Many of our existing paradigms for inclusion are tokenistic. They're set up by organizations to meet a particular purpose that's usually driven by the needs of the organization. And that in itself is a form of structural stigma. But at the same time, there are also structural forces that make engagement challenging without an understanding and knowledge of different players in the system. What that requires is to move away from tokenism, which isn't participation at all, and to be honest about whether or not we can create spaces where initiatives are truly led by individuals with lived experience and their caregivers, or if there may be constraints, because those exist as well. But it's having an honest conversation about what those constraints might be, whether they're legislative related to occupational health and safety, or whether they're financial or other types of structural constraints. Now, an example might be existing labor laws around health and safety, which can lead to very stigmatizing violence prevention practices. Now, those are things that we need to change, and we need to advocate for that change. But sometimes we find ourselves at tables where people who work within organizations agree with people who experience care and want that change, but the target of the change has to be collective advocacy at a different level, at a different jurisdiction around structural policy or legislative change. Just like Dr. Nack says, that requires difficult conversations, and I say it's not safe space as much as it is brave space, but it also has to be an honest space. And I think that I would want to underscore that tokenistic engagement is harmful. It can perpetuate harm and trauma. And what many of us have to recognize is that we have power, and our power is invisible to us, like I said earlier. So the way that those power dynamics play out in engagement really need to be explicit and on the table in order for it to be meaningful from my perspective.
Thank you very much for your response. Would any of the other panelists like to add anything? Dr. Stewart on the phone.
Yeah, I would like to tackle the issue of meaningful involvement. It's come up a couple of times in the chat, and I think it follows along with Javeed's comments. One of the things that we heard from the folks that we talked to is this issue of tokenism. You know, policies are reformed or restructured, and at the very end of the whole process, it's passed in front of somebody who is a designated lived experience person for their rubber stamp. And that is, of course, not meaningful experience. In my world, in the research world, in some parts of the world, we have whole research units that are built around people who have firsthand experience with a mental illness, either own their own personal experience or they're a family member, and these are funded units. And they come at research with such different questions and different approaches. We don't have that in Canada. I don't think we have really tried very hard as a system to make space for people in meaningful ways. And the only way we'll know if we've done that is, first of all, to get them involved at every level of our organization, but secondly, to ask them, what's meaningful to you? How would you like to get involved in this process? And, you know, sometimes there's a lack of technology, there's a lack of organizational skills, a lack of transportation. We have to think of ways of coming over those barriers in order to get people involved. Currently, I think much of what I do is help to give people voice. I don't have necessarily a research unit of people with lived experience, but I can use qualitative methods to help people identify areas that are, you know, problematic for them. But I'd really like to see us go a lot farther and make sure that people do have entrance into the processes before they're a fait accompli, and that they can be very much involved in the development and implementation of things that are important and meaningful to them.
Thank you very much, Dr. Stewart. Any additional responses from the panel before moving on? Dr. Livingston?
Thanks. I guess just piggybacking on this and tying back to an earlier question about quick, easy wins when it comes to changing structural stigma. I think that's often been the problem with anti-stigma efforts, is that we're looking for quick and easy wins, when in fact changing structural stigma is about changing institutions and structures, which take time and investment in order to repair relationships, in order to repair trust that has been broken through what was just mentioned around tokenistic involvement of people with lived experiences or families or other groups. So we can't kid ourselves. These are institutions that are very difficult to shape when we talk about the healthcare system. And I think it's worthwhile looking outside of the institutional system at communities and groups that have kind of given up on the healthcare system and innovated in their own ways to create their own ways of involving people with lived experience and families. And you can look to the harm reduction world, you can look to the peer support world, and you can look to other communities who have found ways to involving people and involving diverse voices when it comes to supporting community members and creating change. And I think there's a lot that the healthcare system can learn outside of the healthcare system by people who have managed to figure some of these things out without being tied to the institutional barriers that are faced within the healthcare system.
Thank you very much, and wonderful questions coming in both when people registered and in the live chat. And I do see that some of our panelists are actually going in and answering some of the questions directly into the chat, so that's fantastic. Thank you for that. The next question, so institutions like hospitals collect their own data and analyze and present it with no true accountability. How can we change how we hold the system accountable and remove this conflict? Any of our panelists, Dr. Ungar?
Yeah, so I mean, the data some hospitals they do report it up to the system, so there is accountability. The trick is, I'm trying to, and I think our structural work of our group, we're trying to actually get up even above the organization to the rules, the policies, even the laws, that what you have to do and where are the incentives and the rewards. Because cash-strapped organizations with tight budgets, if you meet a certain wait time they get more money to operate. And if you don't meet, and unfortunately, we don't have any of our mental health and substance use disorder things on those. So they're just not chasing them. So I will say that capturing the data, but also setting up a data capture system and a reward system where you change the rules of the game and you hack it. So you set up a way that they will do the things we would like to see done better, that are more equitable and address this issue. So the structure of the measuring, the monitoring, the rewards, and the money. We've got to talk about money. People haven't talked about that. So, you know, mental health system gets, what, 7%, whereas it takes up something like 12, 13%, or 7 to 9, takes about 13% of the actual burden of illness. So just that alone, if you just measured that and said if your organization isn't doing a certain amount, something happens, it'll change things. So is capturing the data, but it's what the data they capture and report up is also what they're told to do, and they have to do that. So the impact of the advocacy decision makers, persons with lived experience, if we can actually get to those high-level accountabilities that result in cash transfers, rewards, performance changes, people being let go as leaders of organizations, because you're not doing with how we set the system up. The values behind that are what result in what we measure. And in some cases, we haven't even imagined any of those measures for structural stigma. They don't even exist. We have to create them from scratch. We have to prototype novel things and build them in, and those are really informed by the values we hold.
Thank you very much. I think I will move on to the next question. Is any of the panelists aware of current work related to inclusion of mental health content and education for healthcare practitioners? In particular, the question is asking about nurses, but I think overall healthcare practitioners. Sure.
So I think this is a huge gap, but often our attention shifts to training at the level of health professions schools. Whereas what I would say is we need to shift that frame a little bit. We need to look at continuous training and how we set up training infrastructures in organizations. So to give a case example, when we did our implicit bias training around stigma, there were certain settings where it was more effective and certain settings where it was less effective. The key difference was actually that the settings in which interprofessional teams that worked together, learned together, actually took the intervention further, and different members of an interprofessional team became social reinforcers for change, versus in settings where the different professions learned separately, it wasn't as effective. What that speaks to is the need for more interprofessional training, more case-based training, and more ongoing training. What I'm not suggesting is that we embed it necessarily into a click-the-box I learn that many of us have to do that work in hospital organizations, but rather that we think of organizations as being learning organizations, and that we bring different professional practice infrastructure together to foster team-based and interprofessional learning. That stated, we do need to build more content and include access and exposure, but the problem that often happens is if someone has that training early in their training career, but they get swept up into the culture of stigma in an organization, that training doesn't really last. But it's having regular reinforcers, opportunities to engage in dialogue that can help bring that education to life.
Thank you very much. Would any other of the panelists like to respond? Dr. Stewart on the phone?
Yeah, I just remind everybody that the Mental Health Commission has done a number of different programs that either have been already provided in healthcare sectors such as first responders, or could be adapted to be provided. And I think that there are things out there. Linking back up with the Commission to find out what might be appropriate would be a good thing to do, because we've tested those programs. We know that they're effective. They're not necessarily focusing entirely on structural stigma, but a lot of times what they're doing is focusing on cultural change, which I do think is a structural piece. And certainly with support, we could modify those to include structural stigma pieces in those already existing programs.
Thank you, Heather, for reminding participants of the prior work of the Commission in this area. The next question that I will ask, and I'm just toggling between a couple different chats, so I apologize for the delay. And this is open to all panelists, what do you believe the government's role in addressing and reducing structural stigma is in healthcare settings? Would anyone like to start? Dr. Livingston?
So, I mean, the government is one of the main producers of structural stigma through the inequitable funding of mental health and substance use services. So, I mean, one of the elephants in the room is that there's inadequate resources given to support people who have mental health and substance use needs. And so structural stigma, including coercion, so the reason that there's often crisis-based coercive services is a direct result of poor funding and poor leadership when it comes to the government in relation to adequately funding mental health and substance use services in effective ways. So I think the government has a huge role to play in relation to resource allocation when it comes to structural stigma. And secondly, I mean, repeatedly, so there's the United Nations Convention on Persons with Disability that Canada is a signatory to, and time again, Canada has been found to be not in compliance with it in a number of areas. And so I think the government has a huge role of monitoring on a national, provincial scale the extent to which we're in compliance with that in relation to structural stigma. So I think the government has a role in terms of resourcing and in terms of monitoring and enforcing when it comes to structural stigma.
Thank you, Dr. Livingston. Is there any other panelists who would like to add on to that? Dr. Nack?
Yeah, thank you. I think that it's a great question, and Jamie, you make a great point. And I also think they have a huge role to play in terms of legislation. You know, the Mental Health Act. And, you know, I learned recently one of our champion and change makers that we're featuring is an organization in BC, an advocacy organization that is pushing for a review and revision of the BC Mental Health Act. And, you know, through chatting with them, I learned all kinds of things about the Act that I didn't know about before and that are absolutely abhorrent. That, you know, for example, you know, you can name a legal representative, right, to make care decisions on your behalf if you're not capable. Well, if you are detained under the Act in BC, that no longer legally holds. And your care and your family member or whoever you have named legally no longer can kind of make those decisions on your behalf. And so there was all kinds of things that kind of show up, I guess, you know, in legislation that are reinforcing of structural stigma. And so I think legislation reviews are a big piece of it as well.
Thank you very much, Dr. Nack. Any additional responses before moving on?
It's Heather here. I think one of the areas that is a huge rub for people with severe mental illnesses is disability legislation, and trying to change that so there aren't these clawbacks and ghettos where people are stuck in poverty, making, you know, money that no one could live on, and having any opportunity to work into a job and try it out and fail and go back and fail and go back, taken away from them. It's just impossible for people to really test the waters to see if they can do a job, to take time off when they're not feeling well and to move back into that job and be supported with that legislation. And I know that groups have been trying to change that for years. I think that if people don't have a decent living wage, we can't expect them to do much of anything else. They can't afford their meds in many cases. They can't do leisure activities. They can't get places. They can't do any of the things that the rest of us might take for granted. And I think, you know, follow the money is the big issue. And I think that's one piece of legislation that really does need to be turned over and looked at very carefully from the perspective of the needs of people who have mental health issues.
If I could just jump in, Dr. Stewart's comment ignited a thought for me. I typed it in the chat, but for those of you that don't have access to the chat, something that's been clear with some of our recent work is that structural stigma is interlinked with issues around access to help and treatment seeking for people who work in healthcare. It's a huge problem currently that many organizations require health professionals and employees to disclose mental health treatment seeking and are often punitive towards individuals who work in the system who seek help for themselves. The same is the case for regulators in various ways, shapes, and forms. So I think that as much as we can do to address structural stigma, we also have to think about people who work within organizations. In addition to things like paid sick leave, which is an essential piece to address structural stigma, we have to change some of the structures around how we regulate health professions as well.
And just very quickly to add, just to remind everyone, in Canada, in terms of government, in Canada, we do not have a parity law for mental health yet. They do in the UK, they do in the US. There have been calls for it, national organizations. I know the CMHA was making big noise about that wonderfully. So there's lots of opportunity to just kind of set equitable laws, not to prioritize, but just bring us to equity, because waiting for attitude change and people to figure it out, is a generational prospect. You set some laws, at least people have to abide by the laws in the meantime, or at least try to, while we're working on the attitudinal change.
Thank you very much, Dr. Ungar. And now we're getting closer to the end of the webinar at the correct time of 1:20 Eastern Time. So in terms of, I'm going to give each panelist a moment or two just for some reflections on this conversation and add any additional insights that they may not have been able to do in a very short period of time during their presentations or through the questions. And so really about, where do you see the future of this work, and what are some of the most meaningful programs and principles that can be enacted to address structural stigma in healthcare settings. And I have no particular order and didn't give them advance notice of this question, so I will leave it up to them who would like to address kind of the moving forward first. And I see that Dr. Zakira, so over to you.
Yeah, so just a few comments. Something I'm really struck by is that we can often be a little bit territorial in the mental health community. We can often be a little bit divided into different camps and different groups. We can have a lot of us versus them thinking. And I think that we can also perpetuate a lot of lateral violence towards each other. Yet what I'm really reflecting on is how important it is to come together across these groups and identities because of how united we all are in speaking up and advocating for change. We know that the status quo is not acceptable. We know that individuals who are struggling deserve better, deserve to be treated with dignity. But we often fall into these games around, well, this person and that person and you versus me, when the power of collective advocacy is where it's at. So I think it's through coming together. It's through recognizing that we're all human beings. We're all going to make mistakes. We're all going to stumble along the way. But it's only by working together that we can unite, and the power of that collective advocacy is really my take home. Thanks.
Thank you for those insights. Any member of the panel, Heather on the line? Like to go
Sure,
next?
thanks, Nicholas. I was the one that was working on the qualitative study about measures and what kinds of experiences people have, and it was clear the constructs that they thought were important. I went to the literature to look for measures in each of those areas, and there were none that met my criteria of having been developed with the input of people with lived experience. So mostly they were researchers or people within organizations. And I think it's going to be vitally important to have measures that are meaningful to people who have experienced structural stigma in the system, that are routinely collected and fed back to the system so that they can identify things that need to be changed, the most important things to the people that are receiving services. And so what I see for the next step of this process is to take people who have had lived experience, put them together, and start thinking about how we would like to see measurement evolve in the system. Look at existing scales, look at the items, do they make sense to us? Would we like to change the wording? Would we kick these items out as completely, irrelevant? How could we come up with tools that would make it possible to improve accountability? And I see that as an important next step in the area that I'm working in.
Thank you very much. Who would like to go next? Dr. Nack?
Thanks. Yeah, I think when talking about, you know, what I'm inspired by and what I'm excited by in terms of structural stigma, I think about all of the great work that's already happening and our champions and change makers being one, that there's incredible passion and there has been advocacy work that has been going on for so long. And I think I'm particularly just inspired by the work that is already happening and the dedication and commitment of some of these wonderful organizations and initiatives. And we look forward to being able to share that report in the next couple of months with everybody. The other thing on the measurement piece, I think measurement is incredibly important. It's not very sexy, but I think it's a really, really important piece in how we start to identify a structural stigma, how we start to and actually be able to enact change. Because as I said before, you know, what gets measured is what gets addressed. And I think about this in the context of education and training, that because this is a big piece, it's always going to be a big piece in tackling stigma. And so I think it involves a bit of a shift in focus, that we don't move away from our standard program evaluation type measures and research, but that we also really look at the value of implementation science and how can we use the principles of implementation science to really start to embed and track what the education and training is actually doing, and how we're getting more and more people on board and how we're actually enacting cultural change that way. I'll leave it at that. Thanks.
Thank you, Dr. Nack. Dr. Ungar or Dr. Livingston? Dr. Livingston.
Thanks, Nicholas. I think that what I find particularly exciting, and I think this is mentioned by some of the panelists previously, but the capacity for the public to think structurally has grown incredibly over the past year or so. And so whether or not that's related to decriminalizing drugs and the ability to think structurally in relation to how to affect change in ways that really matter to the health of people with lived experience of substance use issues, or to think structurally about how to adjust the way that we respond to mental health crises in a way that has a big difference for people who are in mental health crises, for example. So I find that particularly exciting in relation to this work on structural stigma, is that it's no longer so much of a sell because people's capacity to think structurally has been enhanced. But secondly, you know, my work is in the area of criminal justice and the intersection of mental health, substance use, and the criminal justice system. I think where I would like to see some of this work going is around finding alternatives that don't involve increasing the capacity of our criminal justice systems to deliver mental health services, but finding other ways of addressing harms that don't involve placing people within the criminal justice system or promoting their involvement with criminal justice agents. And so I think there's a lot that can be done in relation to addressing structural stigma that will eventually reduce the criminalization of people with mental health and substance use issues.
Last but certainly not least, Dr. Ungar, over to you for final thoughts from the panel.
Yeah, so I just want to echo the optimism that Stephanie and everyone showed and the great work being done. We're really breaking new ground in Frontier, I think, in the activities we're doing. So hopefully that itself will just carry on. But I think the real targets that I'm thinking would be the most important is really trying to get the champion leader change agent to get it first, because without that, it doesn't really happen at that big systemic structural level as easily. I mean, they do come together, the grassroots and the top, but I think, at least in my field, is getting the top and understanding what drives them, because I do think they want to do the right thing. And it's such an abstract concept for most people still, the structural thing. I think I was always shocked as we did our work and we presented concrete, silly little examples. Emptying a garbage can isn't done equitably. You don't get the same quality of lunch on some units. Well, that's not true. I'm making that one up. But those kinds of real practical things really resonate this abstract concept, because they don't even want to hear about structural stigma. They want to see about what exactly is happening that's not equitable. We can't let that happen. It's a 6-month wait for this. It's a 3-week wait for that. What's that about? That kind of resonates. If you just talk about the abstract concept, it's a little harder for them to know what to do. So getting those lead people and really driving home an example of something very minute that's very relatable.
Thank you very much. I think that sums up the panel brilliantly, and I want to thank each of the panelists for taking the time today to be with us and share their knowledge and expertise, and to each of you who have been participating through the chat and who have sent questions in advance. I think it's been a very stimulating dialogue. The Commission is looking to continue this important work for the next many years, and so really appreciate your participation. We hope that you will be able to stay for a moment and fill out a few evaluation questions, as we are always looking to improve how we provide this information and through our webinars. So you'll see a few questions on your screen now, and if you could take a bit of time to answer those, that would be helpful, and we can look to incorporate that feedback into future events. So please take a moment, and we appreciate you being with us here today, and thank you very much.
This does conclude today's webinar. Have a great day.